I saw a new client today and I wanted to give you a rundown on how the evaluation worked, just to further have you understand how I use the movement map and my thoughts, my treatment approach. He dislocated his left shoulder previously this year. He's had, this is his second full dislocation, probably even more, has had more even, maybe that were not, that were dislocation, but like relocated itself, so subluxed. His original one was 10 years ago, and he was actually pretty good for 10 years, but since this last dislocation earlier this year, he has still had a lot of feelings of instability and a lot of pain, and it's limited him in doing his work activities, which are sport related. He works in baseball, so things like throwing, catching, etc. Well, not throwing, because it's not a throwing arm, but catching the ball, fielding the ball, that etc. So I explained to him that the evaluation was going to identify where his body was protecting, and that may or may not be related to the shoulder at all, but how it relates to the shoulder is that when you are constantly in a protective response, like a sympathetic nervous system state, your body has a harder time healing itself, recovering, etc. So his evaluation, his listening was to the back side of his left pelvis. And I thought there was maybe a little cranial piece too on the right, but it was hard to tell in just the general listening, so I relied on the locator tests to help me figure out where to start. So I used the SI joint shear test. That was positive on the left. I used his pulses. His pulses were more faint on the left. When I inhibited the left posterior hip, his pulse got better on both the right and the left leg, so that confirmed the left posterior hip. And upper body, when I checked his pulses upper body, they were equal bilateral, so I wasn't thinking upper body or neck or head anymore because of that. Once I confirmed it was left posterior hip, then I think in that area, then I paused and I tested all the orthopedic things in his lower extremity and his upper extremity. And in his lower extremity, he was limited in hip flexion, hip abduction, quite significantly in hip flexion. His pelvis started to side bend at about 75 degrees of hip flexion. His leg was really heavy on that side, which is also a typical neural type of response I notice on people. His opposite side was about 90 degrees of hip flexion. His bent knee extension at 75 degrees, because I wanted to match both sides, was full, no problem. On his left, it was lacking about 20 degrees of knee extension. Then his shoulder, I wanted to check his shoulder, even though I wasn't treating his shoulder, because I wanted to see how it was relating to his issue, which was the left shoulder. His left shoulder abduction was about 45 degrees. His internal rotation was about 10 degrees at the 45 degrees of abduction, with his feelings like a deep joint uncomfortable feeling. Internal rotation was fairly unremarkable. Shoulder flexion passively, I could bring him up about 110 before it looked really uncomfortable and he was feeling like a discomfort at the top of his shoulder. Active, he was painful with shoulder flexion, could not abduct without feelings of instability. Scapular relocation test didn't really do a ton. Felt a little bit better, but it didn't significantly change anything. His scapular posture was down or upwardly rotated on the left, slightly depressed, though more elevated than the other one. So it was still depressed, but it was elevated for him. His humeral head was about half of the humeral head forward of the AC joint, so he had an anterior humeral head position. In standing, things got a little bit better than they were in seated from a postural standpoint. I think that's it. Oh, the other thing that I tested in prone was the knee bend, and he had a positive Lesegs test, or the femoral nerve root. It didn't seem to change with abduction or adduction. He was about 25-30 degrees of knee flexion before his lumbar spine extended and pelvis rotated on both sides, with a lot of tension on the left quad, left leg, hip flexor type thing. So, treated his hip. So the only organ in that area, right, that the muscles would be protecting are nerves. So I treated his nerve all along the border of the sacrum. I did some neural techniques, opened up the space between the sacrotuberous ligament and sacrospinous ligament. So though I do, after that, I did the sciatic nerve treatment, and then I decided to use the dynamic cups to do a skin lift technique along the line of the inferior gluteal nerve and the superior gluteal nerve. And I ended up doing those nerves, but then just pretty much the whole cheek, because he was liking how it felt, and I was feeling like it was responding well to that skin lift type technique. So we did that, and then rechecked his hip flexion, and that he was like 100 plus degrees after that. And his leg still wasn't quite light enough, so after more inspection of the nerve, I felt like I needed to do his spinal dura, which is just an elongation technique of the sacrum to the cranium at different points of the curve. So an exercise that would be good for that, which is always a good thing to do whenever you've treated a peripheral nerve, is to bring it back into the spinal cord and the cranium, would be the pelvic rocking exercises, or a segmental cat-camel would be great. A standing roll down would be great. Any sort of segmental spine movement or pelvic widening technique would be awesome to do and helpful. So I did that, and then that freed up the rest of his leg. So that was cool. So then it also normalized his pulse and his legs. So then we took it to his cranium. He did have a little like dural piece in his cranium that I did. So I picked this up on the locator test at the mastoid process. So his right mastoid process was more prominent. So I put him in right side bending, and I did the dural technique. From here, I would do from an exercise standpoint, a good one could have been cervical rotation with the Franklin ball, which is on the Vimeo channel, or I could have done cat-camel here, focusing on head and neck control. Could have done trigeminal nerve, right, because the tentorium relationship to the trigeminal nerve. I could have tested and done face stim, or just done face stimulation on the right side. Could have done humming. Could have done a lot of stuff to address the cranial piece. But obviously my tool is the neural manipulation, so that's the quickest tool to use. So that's what I use, but I'm just trying to point out that there's other ways you can do it than that. Then that significantly improved his head and neck posture, laying in supine, which was like this, and then when we finished it was like this. From there, I then rechecked his shoulder range of motion, and his abduction went to about 85 degrees of abduction. So he gained about 40 degrees of abduction just by treating his left hip and nervous system, right? So that's great. External rotation, he gained a lot of range of motion, but he still did not like how it felt. But range of motion went from about, what would I say, he had like 10 degrees, went to about 40. Shoulder flexion was a more like 110, 120, so, and it just felt better going into it. So from there, I went ahead and did a little specific stuff to his shoulder. And I talked to him about the reason for this. I wouldn't have done anything to his shoulder until I got him out of that protective response. In fact, even before I did work on his shoulder, after I reassessed his range of motion, we reassessed active too. The range of motion looked a little bit better, but it still was pretty comfortable for him in the end range of shoulder flexion. I did not retest shoulder abduction, but he looked really good with just 0 to 90. After I rechecked those before I did treatment on the shoulder, I checked his pulse. So originally I used a pulse ox in his upper extremity just to see what his resting pulse was when we began the treatment, which was about 57 to 59 beats per minute. And he noticeably told me he was more relaxed by that point in the treatment session. You could see that he was more relaxed. So it was safe to say that we probably did switch him into that parasympathetic nervous system state. But I don't want to treat the area that's painful until the body was ready to do it, right? Which was an important part of following the listening and treating the left hip first. Then I retested his pulse, and his pulse was 52 beats per minute on both sides. So he was significantly lower. So then I felt like, okay, yeah, we can do some stuff to your shoulder. And from there, the first thing I did, since he had just gained some range of motion, is did some iso holds just to let him activate his rotator cuff a little bit and provide some stability so he felt safer. And then I laid him on his side, and I did some work around his clavicle, and I did, which ended up actually being the distal part of his clavicle, so it was around his AC joint. That cleared up some shoulder flexion as well. And then I did glenohumeral joint compression of the joint. So I compressed, and then I followed where the joint wanted me to take. So I did a little bit of a compression style induction joint mobilization. Then I did a little bit of his clavicular pectoral fascia, a little just like myofascial release type technique, a lifting of the fascia in that area. And then I was like, okay, we're done, because I changed his range of motion a bunch. When I rechecked his range of motion after those the AC joint and the glenohumeral joint stuff, his range of motion into abduction was to 90 degrees, and his shoulder was still about 110 to 120, but it looked better and felt better going into that range. External rotation is still improved, so I stopped there because of a couple of reasons. One, I'd already done a lot on him, and I didn't want to confuse his brain on where the work was to be done, which was his nervous system. And then two, because of his history of dislocating and his instability, I don't want to give him so much new range of motion that he goes home and reaches and dislocates his arm, right? So I wanted to keep a little bit of the protection stuff around his shoulder. So of course, if I cupped him and needled him and did a ton of joint moves, I would have probably improved his range of motion more, but that's not necessarily the right thing, right? And so my suggestions to him for the next couple of days was, one, pay attention to how he feels, and to honor how he feels when he's doing shoulder rehab. He's also a physical therapist and a strength coach. I don't need to teach him how to do exercises. He knows how to do exercises. Eventually, I might need to help him learn how to clean them up better. But in this phase, right now, I just need him to honor that his body knows best where he's at, and let it be his guide. So that means staying in the range of motion that your body feels comfortable, right? And he even said, yeah, I feel like I want to just like move through my whole range of motion. And I'm like, yeah, but your body doesn't want to. So I said, you feel good through 0 to 90. I said, so that's where you should live. I was like, and the more you tell your shoulder good messages, the easier it will start opening up on its own, right? The body does not like to be forced. That was his homework. I might end up giving him stuff around that left hip. We'll just kind of see. I'd like to see him back and see how his body responded to it all. But that's it. There's a lot of explaining to him the role of the nervous system. Like, if I wanted to give him stuff, I probably would have given him stuff around breathing. And I probably would have given him the segmental spine stuff. But sometimes I just want people to sort of like enjoy feeling better and just start paying attention, because the first thing I always want to teach people is to trust the wisdom of their body. And so I was like, yeah, I just want you to kind of like be good about tuning in and seeing how you feel for the next couple of days, and then report back and we'll create a plan. Hopefully that makes sense and you start to see how important the locator tests are to figure out where to start, because I cannot emphasize enough, starting in the right place makes all the difference. You can have the shittiest technique in the right place is better than the best technique in the wrong place. The wrong place being the place that the clinician thinks is the most important. I would have been easily distracted by his shoulder. There was a lot in his shoulder that looked wrong, right? There was a lot in his rib cage that looked wrong. There was a lot in his ankle mobility that looked wrong. Plenty of spots that I could have assumed great manual therapy would have made a difference. And it would have maybe for that day, but we would have been right back where we started, right? So honoring where his body's at, meeting it where it is, treating where the body wants, and then not doing too much is really the key. And appreciating that he has a joint that's unstable, and if I take away all of its stability, then that's just gonna make things worse, right?